So we are going to present some of our findings in relation to a study that we did with a whole group of partner organisations within an overarching research project around the people who are homeless and the nurse-led approaches in COVID-19. So you'll see quite a few people who are involved in the project are here in the audience. It was very much a collaborative affair, and you'll see posters in relation to different aspects of the project outside. And indeed, we have the executive summary here as well. If anybody wants to pick one up, you're more than welcome. Okay, so basically, as I mentioned, it's an analysis. The study was an analysis of nurse-led interventions among homeless populations in the context of COVID. We are presenting on behalf of a wider group, and that group includes, you can see some of the co-investigators there from a whole range of homeless services, both statutory, HSE and NGOs, and it was an absolute delight to work together. But as you can imagine, quite challenging as well, because every service works differently and has different client populations and all of that. So it was a really interesting project. Myself and Fiona were the co-PIs on the study. Fiona is the CEO from Safety Net Primary Care, so a very powerful, wide-reaching organisation who actually supported quite a few of these projects on an ongoing basis. So that's really good. The funding came from the RCQPS through a competitive funding bid. So that was really nice that they backed this kind of really grassroots research. So just, I mean, people I don't need to spell out, and kind of some of the background issues here. I think Colette raised them really well in her presentations this morning, and so that really is just echoing really what Colette has pointed out, the whole kind of COVID-19 in the first instance, and then the homeless populations are particularly vulnerable for a whole range of factors, both within their own health situations and the surrounding contextual health care system, and inequities and exclusions and all of those, right through to housing as well, and unstable housing, contagion risks. We reckoned, we're a bit biased, but we reckon that nurses, are kind of the most accessible members of healthcare teams, and to do this research, that really was important to kind of get the views of nurses who are actually really working in this area, working at the coalface, so to speak. Because knowledge in this area is still at a very early stage of development, both obviously in terms of COVID, but more particularly in terms of marginalised populations. You can see our research aims and objectives there, that we wanted to find out more about how a nurse practice worked within, or in fact didn't work sometimes, within this whole area. And to do that, we collected practice case studies. So that was like a whole service case study for each of the services that we mentioned there. And using tried and tested healthcare quality evaluation frameworks, we analysed the strengths and the limitations of the nurse-led interventions. And then when we had all the case studies done individually, then we did a cross-case analysis to compare between the case studies, what were good examples, what held true across all cases, what was different in some cases. So just in terms of the methodology, we used mixed methods there. As I mentioned, the 6 case studies, and case study research is really a very powerful way of capturing. You can capture both quantitative data, and you can also capture like really rich qualitative data as well about a particular case. Now you can see there, I know I whizzed through the contributors, but you can really see the range of services that we had within this project. Which was really, we got really rich findings. And all of them have different aspects that they consider to be their strengths within the COVID piece. Like, for example, the Homeless Health Link are very interested in remote interventions. And that was really interesting, you know, from coming on from Pamela's talk this morning as well. The whole area of health liaison, inclusion health liaison nursing, which is a hugely important thing. Again, Colette has brought this up. Pamela as well, talking about integrated care and the importance of that, especially with marginalised groups. The emergency COVID-19 response, which was safety net, which was like working, all of these services were working at the coalface, but safety net were kind of, in some ways, maybe more mobile, more sort of front-facing in terms of people who were extremely marginalised, maybe sleeping rough, people in various communities that were particularly hard to reach. So a lot of outreach work done there, as well as a whole load of other services. People who were kind of moving from hospital type situations into the community, how were they going to be managed? So we had Dublin Simon community, they're kind of really working with that particular group in terms of shielding, isolation, cocooning, all of those kind of things. And then Peter McVerry Trust, they worked like really intensively with people in shielding and isolation, but with a particular focus on kind of mental health needs and addiction support needs, which was really interesting. Byproduct, if you like, not really a byproduct, but a very positive, opportunistic way of working with people in the context. People say don't waste a good crisis, and they certainly did not waste a good crisis there. And then we had the nurse-led responses in Balseskin Refugee Centre. So, I mean, right, you know, when we talk about, and again, not to be going on about Colette's speech, but also Sabina's talk as well this morning about, you know, those barriers for healthcare people, yeah, and for service users coming from one country to another, bringing, you know, kind of various richness, but also various diseases as well, COVID being one of them. And so how that was managed in a reception centre. You can see there the data collection. It was a mixture of qualitative and quantitative. We used the two models we used was the Donabedian model and the Institute of Medicine. And you can see there we were looking at things like, you know, was the care safe, effective, patient-centred, timely, equitable and efficient in terms of structure, in terms of process, and in terms of outcomes. And so you can see there's a whole range of how we collected data. That's in the executive summary as well. We had a range of analysis as well for our qualitative analysis and statistical, and then we triangulated the data, and then we did a cross-case analysis. Okay, so some of the findings, which Fiona's going to talk about in more depth in a moment, but we divided them really into particular areas across all these services and all these case studies. So there was, like, how was that service provision governed? You know, what was the governance of that? The service user characteristics and support needs, which Pamela mentioned how important it is, the kind of the social and cultural aspects, the actual COVID-19 care interventions that were given, which were examined in terms of all of those characteristics from the quality frameworks. And then the actual overall patient care systems, which we've talked about in the last couple of presentations, and the implications as well for inclusion, health, nurse practice and professional development. So Fiona's going to talk to the first three, and I'll finish off on the last one. All right?
Thanks, Briege, and thank you for inviting me to share this presentation. Definitely the lion's share of the formal kind of analysis and the research was Briege and her team. And I'm one of many of the actual the case studies and the people, the practitioners that were involved in this study. Just some of the findings, as Briege says, on service provision. Across the case studies, it was found that, you know, staffing levels were adequate at wave one, but as COVID impacted staffing, you know, and people got sick and redeployed, staffing declined, and obviously as services expanded as well, there was staff capacity issues. There was a lack of initial preparedness. Basically, you know, COVID got us all, pandemic got us all by surprise, and there was a lack of preparedness. So there's some of the findings you can see there. But I suppose specific to the area and homeless populations and vulnerable populations, there was additional safety measures put in by the nursing staff for the populations who had particular vulnerabilities, and nurses were keenly aware of safeguarding issues, and that came across the case studies. Some of the recommendations for the governance were, as seen, I've just grouped them into recommendations on staffing and recommendations on patient, you know, that will affect patients. And on the staffing, you know, obviously a review of staffing levels, so if this were to happen again, that we wouldn't be depleting other normal services by redeploying staff. So a review on that needs to be done. You can see the other kind of governance type issues, more training for staff, and well-being and psychology and debriefing for nursing staff post-pandemic. You know, that would need to be done. It hasn't been done, you know, by the authorities and the HSE. And in fact, I'll just get the point in to say the payment that was given to the HSE people, you know, in appreciation for the work done, was not given to the NGOs and ourselves, and who were at the front line. So that impacts on well-being and psychology, you know, and psychological safety of staff when you're not felt appreciated. Looking at the patient, the government's issues for the patients, you know, basically the whole identification of vulnerabilities through screening and other prevention. This was done, and opportunities were taken across case studies to do this, but you know, in terms of recommendation, this needs to be definitely built on going into the future. Some of the findings with the characteristics and support needs of the client group, the nurses across the case studies dealt with a really wide range of ethnicities in terms of age, and there was a huge amount of complex medical and psychological needs. And a very broad scope of nursing practice was seen across the case studies, you know, with, you know, from anything from, you know, dealing with assessments for newborns to providing end-of-life palliative care and allowing people in vulnerable situations and homeless situations die with dignity. There was a very wide range of nursing specialist expertise seen across the case studies as well, with midwifery and childcare, migrant health care, addiction and mental health support. And all services provided education and IPC support, and additionally went further to protect their client groups who had additional vulnerabilities and mental health challenges and addiction. There was a tension noted in some of the case studies between the imperative of maintaining, you know, the IPC and the isolation and the cocooning, and compromising the service users' autonomy and rights, you know, particularly when people had to be moved from a very congregated setting to an isolated setting, and nurses had to deal with, you know, navigating, you know, the safety for everybody in congregated settings and the patient's own right. Like, no one came into my sitting room and said, "You've got COVID, get out, we're moving you." And so the nursing staff really had to navigate that very sensitively with the patients. We would see that across the case studies that there is an opportunity for improved service user and patient involvement in future response planning and design. Some of the interventions in terms of the findings, in terms of triage, you know, there was really good safe and effective and efficient practice across the IOM domains, seeing in triage and assessments. In terms of COVID testing, initially it was the lab nationally, there was backups and there was delays, and that impacted provision, but very quickly this improved, and there was speedy results using the new innovative technology of the gene expert. In contact tracing, nurses were involved in a lot of the contact tracing, which had to be done really differently and designed differently for the particular groups that don't have addresses, that it's difficult to find out who they were with, that speak different languages, and it was found that they were timely and innovative and efficient as well. And then the isolation and cocooning and monitoring, nurse-led monitoring of the physical and mental well-being of people in isolation, and this was really nurses on site, 24/7, and this was seen to be safe, effective, efficient, and timely. Just on the care interventions, again, I've mentioned the addiction, and this is largely, I think, through the McFerry case study, there was a huge amount of innovative work, and people particularly identified and stabilized on their opioid substitution therapy was better and more efficient than it was in normal times, and learning needs to happen about that and how to spread it, and expand on it in normal times. There was opportunistic treatment and identification of disease by nurses dealing with in the migrant population, specifically the Roma, and the Health Link team. I'm looking at Max down there, who did a lot on this, and the amount of diseases that wouldn't have been detected otherwise and treated. And then the mental health care was huge, and that's just a number of the interventions carried out by nurses, and that again was seen to be safe, effective, efficient, and timely. Where things could have been improved, we think, in the future is, when the lockdowns came and everything, kind of stopped, there was a reduction in addiction relapse prevention work, loss of usual specialist services, and of course lack of normal social communication opportunities, which impacted severely on enduring mental health problems. There are some of the recommendations, and as Briege says, these will be handed out in terms of the care interventions. Just as an example, we recommend training in trauma-informed care and a good understanding of the triggering potential of lockdowns and isolation on people who have suffered trauma, which is most of this client group, and other increased development of services for homeless people in general with chronic diseases, and a review of the effective practice and strategies that I have mentioned in the drug stabilisation that went on in isolation. The patient care systems and inclusion health nurse practice, Briege is going to continue about that.
Okay. Thank you, Fiona. It's great, we were very busy. Okay, so so what does this mean as well in terms of some of the patient care systems? Overall, despite an awful lot of the disruption and stuff, the patient care systems, when it actually came to the nurse-led services, were remarkably efficient. People were taken in, admitted, and got treatment within those kind of care systems as quickly as possible. And that was due to a whole load of factors. I suppose there was a fear, amongst government that this group really needed support. So fair play, they actually did come up with the goods. And I suppose the question is, well, they need to continue coming up with the goods, not just, and that's one of the biggest takeaways from this, is what can be done in the context of a pandemic, and why can't that be done? As Van Morrison says, wouldn't it be great if it was like this all the time? So that was great. We were able to do that. Care as usual, Fiona mentioned that already. Nurses did do their best to try and maintain care as usual, and even went above and beyond in terms of, stretching their scope of practice. Even, giving things like maternity care, foot care, all sorts of things, because regular clinics may not be open. Sexual health, all sorts of things that nurses kind of actually got involved in. So learning curves for nurses as well. Again, the discharge and follow-up, there was implications, because you can imagine somebody with an addiction or whatever, or multiple addictions, trying to get them transferred back out into their own area, and the support services maybe not being in place because of COVID or pure lack of staff and all of that. So sometimes people stayed in residential services longer than maybe they should have. So that could cause a bit of a backup. And we have to acknowledge that some people returned to the streets in the context of COVID because there was just nowhere for them to go, or else they did not want to be in the accommodation that was there, because often that can be traumatic for them as well. So there's a lot of work needs to be done on that. The interdisciplinary and interagency working, that was another really positive thing that came out from the study, and then amongst the services that were in the case, the 6 case studies, you could really see the connections between those services, like who gave who a dig out with this aspect, and who came in, and Safety Net came in and did this piece. Some of the nurses may not have been trained in PCR testing and stuff like that. So Safety Net would have come in. Peter McVerry might have given advice about addiction support. The inclusion health people would have kind of had an overview of people that would have been rotating throughout all the services, and again worked with all of the services. Again, and Dublin, Simon, the vulnerable populations, and Balseskin. So all of them kind of really worked together in terms of mass screening, in terms of kind of jumping in whenever they were needed. Again, the communication and assessment between the teams, was pretty good in terms of client assessments and interventions. We all had the Zoom, the video conferencing, and you can imagine the challenges of that. Even though it worked surprisingly well, it required a lot of support from nurses, but you can imagine people with different languages. Colette mentioned the group of people who don't have technology, not familiar with technology, and we all talk about having to pivot, the famous word pivot, and you can imagine people already compromised by addictions, homelessness, having to pivot in this circumstances. So nurses did a lot to try and support that as well. It's just some challenges there. Now, the other challenge is around the patient recording systems, which speaks to what Pamela was talking about earlier on. That within, we have a long way to go, and I think anybody working in any health service today that says they have it right, kind of needs to kind of think a bit more about it, because there's all sorts of recording systems that people are using, and then throw a pandemic on the top of that, and when people are put to the pin in their collar, they're running just to get their daily work covered. Recording was not always done. Sometimes there's different systems. When you look at testing, you have maybe 3 or 4 labs at the start that people were sending their results or their samples to. Different systems, the inpatient system maybe not speaking so well to the community kind of systems. So the pandemic really showed up the importance of having a coherent system and the gaps in that system. And indeed that impacted on some of our study findings, because we were saying, okay, let's have your desk data, folks. And sometimes people were kind of scratching their heads, no more than any of us would. Because hang on, we were just keeping body and soul together here. Also things like outreach work. We have to think about how do we, Pam talked about interoperability and user-friendliness of data. How do we record those things when you're out on the street, you're doing outreach work? So the realities of practice really were thrown up in the pandemic. So, also then this big piece around inclusion health, because, we could say, oh, these nurses were amazing in the pandemic, and they were. There's no doubt about that. There was challenges, obviously, as well, and there's some things that nurses, being reflective people, also highlighted that could have been done better. Some of that was from a systems perspective in terms of the lack of support that they had. Some of it was from just nursing and the nature of nursing and the nature of our roles and our scope and our ability sometimes to be recognised that yes, we can do that. That's not our ability, but so some of those kind of things limited nurses to a certain extent. But one thing that came across really strongly was the breadth of nursing skills. And that comes out in the literature as well. There's American and European literature, is particularly in the area of addiction, which kind of is really pushing for nurse practitioners being addiction specialists and actually been recognised as addiction specialists because they do so much of that work. I would suggest also in terms of migrant health, in terms of child and family health, there's so many areas. But in relation to inclusion health in particular, well, surprise, surprise, we're biased in that area. But we really feel that, I think as a group, we all are part of the Nurses and Midwives for Inclusion Health Collective. And we really are pushing towards, kind of national policy, nursing, wider management, recognising the work that has been done. Because in some ways, people who actually work with marginalised populations also get marginalised. So I think it's really important that the work of inclusion health nurses are recognised and that there is a career pathway. And so, you'll see in some of the I'll not go through all of these, but you can see that some of those things are come up in our recommendations, both in terms of, kind of the systems for people in these kind of situations, the care as usual, that if we look after our homeless population, that they're in a reasonable state of health, well, it stands a sense that pandemics are not going to affect their health to the same extent as they do, especially think Roma populations and all of that. So, we take good care of people, both housing and health-wise. And we look after basically the people who care for them. The two take-home messages really from the whole study, like surprise, surprise. But this is the kind of things that we're talking about here. That's some of the implications for nurse practitioners. And it's really importantly to acknowledge that our study was about nurse practitioners, but this is about all practitioners that work in inclusion health. Like, we work within a multidisciplinary team and integrated care, and that lots of these findings apply to any practitioner that is working in these marginalised contexts. And so we are delighted that we work in the context of really good teams. And that's about it, really.